Yes, I've been around for a long time. A little bit scary. It's been a journey. Um, and it means that I've made a lot of mistakes, which is what we call experience. Experience is learning about what doesn't work and what can be done better. And this is what I will try to do. So I'm going to divide it into what I call chapters. So chapter, kind of like, when you make a movie and you don't want to really, duplicate a lot of scenes, so you divide it. In the first part, I want to touch up a little bit about what we've understood, and we've tried to kind of appreciate what's the underlying basis. And that leads me to the second chapter and the tools, tools meaning the different ways of trying to manage this. And then the third part, which I think is probably the most crucial to all of you, is what does it really mean at the end of the day? How does it change what we do so that your day-to-day life and your quality is really going to change and be impactfully affected in a matter where you're able to do more of the things that you would expect of yourself. So let's start with the first chapter. What is it? What's the underlying pinning? And the first thing that I think has changed since I started in this field more than 30 years ago is to stop thinking about it as a disorder of the pituitary. It's not. It's a syndrome. It's what I call a multi-organ disorder that affects pretty much every part of the body. And I think it's very important to appreciate the different facets. Why? Because these are what ultimately come into the equation of how we're going to manage it. So from the top all the way, some of the things that affect what we talked about before with the headaches, the vision, but then it goes into the heart. And the heart is one of the things that we don't talk a lot about. But at the end of the day, it used to be, and it still is, a major problem that plagues this condition. The heart, as you'll see in a minute, literally, no pun intended, is at the core of it. And I know it's somewhat simplistic, but I want you to appreciate this fact because we're going to come back to it. How well your heart functions as a pump that's able to contract and relax properly is crucial to how you feel. We're going to come back to that point. The other part of the heart, the yin to that yang, is the lungs. The lungs have to work really well because without the pumping action, without getting the oxygen, it's basically the ABCs. And it's ironic that we had to go back to the fundamentals to be able to understand why people don't feel well. And that's one of the things that I really tried very hard over the years is why is it that sometimes patients walk through the door and they just don't feel well? And the immediate thing is for doctors to look at the numbers, look at the chart, look at the blood test results, and look at the MRIs. And when everything fits beautifully, it's easy. It's a slam dunk. But when it doesn't, there's nothing more dissatisfying than for the patient to walk out without an answer, and the doctor doesn't have any idea, and it gets left off. And this is the reason why medicine is falling behind compared to so-called alternative medicine, because alternative medicine is trying to give answers to people who don't get answers. It's to be expected. It's one of the things that I have noted more and more over the years. So we'll come back to again. Because at the end of the day, the syndrome where the heart can't pump, the oxygen is not coming through the lungs properly, then things start to fall apart. The joints hurt, the bowels don't work. And at the end of the day, this is what people complain of as I don't feel well. Their quality of life goes down. Now, whether they pin it or they ascribe it to the headaches, to the sweating, to the joint pains, it doesn't really matter. At the end of the day, I feel like crap, doctor. What are you going to do about it? What's the underlying cause? That's really what it comes down to. And sometimes it's hard because if you're not very well, it's hard for you to articulate. And if the doctor doesn't understand and you don't know, then obviously you can imagine there's a very big disconnect. At the end of the day, it used to be, And to a large extent, it still is not only an impairment of quality of life, but also of survival. There's a reduced survival. Part of that was alleviated by the fact that some of the easier things have been done, because we can manage the blood sugar and the blood pressure and the cholesterol a little bit more easily, because those are tangibles, those are numbers. We don't even need a doctor, quite frankly, for that. We can get a computer to do that. This is to give you some idea. Dr. Shereen, Omar Shereen, was actually an endocrinologist here in Montreal for many, many years. And he and I used to work closely together until he retired several years ago. And we collected about 650 patients from across Canada. We published this paper back in 2013. And this was just to show you of what acromegaly looked like in Canada. And still you could see that about a third of patients still had diabetes, hypertension, and a third of them, despite treatment, still had sleep apnea. And it became obvious that there was an increase in mortality, and our colleagues in the US basically showed the same thing. But the important thing was that it wasn't just about growth hormone, and it wasn't just about because whenever people tried to say, okay, here's your growth hormone, here's your IGF-1, bring those numbers under control, then life is going to be hunky-dory, really wasn't enough. There clearly was a lot more to it than that. So going back to the drawing board, this is again remember this is chapter 1, we're trying to figure out why things go wrong. So the thinking was that there's a small tumor, it's a tumor that makes growth hormone, produces too much growth hormone, meaning too much IGF-1, both of these contribute to the problems. That was a very simplistic approach, and the reason why it was so simplistic is because it implied that everything that was going on was happening in the blood, and therefore if you did a blood test, you should be able to see what's wrong. Over the years, we start to understand that this is part of the story, that much more was going on in the tissues. And it turns out, first of all, every single cell in your body has growth hormone receptor. There isn't a single cell in your body that does not have it. That poses a bit of a problem, because knowing what's happening in your tissues is not always necessarily reflected by what's measured in the blood. Sometimes it is, sometimes it's not. There can be a discrepancy. Why? Because both growth hormone and IGF-1 are associated with proteins, partners that allow for them to be able to circulate. They don't move along on their own. And the reason for that, if you want to understand, is that if you cut yourself, for example, or somebody takes part of your liver out, you have to regenerate, and the body therefore has to generate a signal that allows for regrowth, healing. And every day we have healing going on in our bodies. Sometimes it happens in a normal way, sometimes in an abnormal way. Point is that what's happening on a day-to-day basis, even minute-to-minute basis, going on in your tissues is not always very easily correlated by what's happening in the blood. So that was part of a problem. So we had to go back and really try and understand, and one of the things that happened over the years, and one of the areas that I think we've made some progress, is we started to be able to go back and say, is really what's happening in the pituitary so incredibly benign? And that was the term adenoma, which implied a benign growth doesn't do anything, and if you cut it out, everything should be perfect. Well, you heard, as from our last presentation, the gentleman that Marie was talking about died from metastatic disease. Not all tumors are so innocent. And what we ended up having to do was go to the WHO, and I sit as a member of the WHO on a classification of endocrine tumors, along with some of my colleagues from the US and other countries. And we managed to be able to get the WHO to accept the term adenoma is inappropriate for these lesions. And that's how things got started, and we were able to get them to fall and classify them under the umbrella of neuroendocrine tumors. Now you say, well, what the heck is that term, and what does it mean? And does it mean it's cancer? It is not. It is not a matter of cancer. It's a matter of having to be able to say that tumors of the pituitary gland are much more akin to other tumors that are in the endocrine system, including those of the lung, of the pancreas, of the small bowel, and other endocrine cells in the body. This is what we call neuroendocrine tumors, and this is a large family, and we can actually map them with specific markers that we can measure in the tissue, so that, God forbid, you end up with a tumor in your spine or in your liver, we can actually trace and find out where it started. And we can tell that it was starting from the pituitary, and specifically which cells in the pituitary. We can do the same also to be able to determine, do you have a genetic predisposition that has created the tumors in the pituitary, the parathyroid, and the pancreas, or maybe even some atypical combinations thereof. And we talked a little bit earlier about that. And that's where the genetics, the pathology, the biochemistry, the imaging is all coming together to bring all of these conditions to make sense, rather than for them to be what I call orphans. Orphans are really a reflection of inadequate knowledge, meaning you don't know. All of you, every one of you, even if you've been adopted, you're a member of a family, right? And knowing your heritage is crucial about knowing who you are. This is the same story here. This is talking about the heritage of what's in your head, so that you know what to expect. It's a member of a family. So that was a major undertaking to be able to understand that there is, in fact, such a thing as a family of neuroendocrine tumors. And within that family, there are specific tumors, and we can map them, and we can tell also where, just like you are as a family member, are you first generation, second generation, third generation? That's what we talk about with tumors. How mature, differentiated, primitive, or even poorly differentiated, because that will tell us some idea of how it's going to behave or misbehave, and how it's going to respond to different types of therapies. And indeed, we started, both my wife and I, who actually is the person who teaches me everything. This is, by the way, why I have a scar over my head, because when I get it wrong, I get banged on the head. So I'm trying to get it right. And obviously, as you can see, this is a fresh scar, which means I'm still making mistakes. But we wrote a paper several years ago that got criticized because we started by indicating that acromegaly is not just one disease. Just like you're not the only member of that family. You have siblings. You got males and females. You got young and old. And really what we tried to do was to try to get the people, especially in endocrinology, who typically tend to be very, very, shall we say, I wanted to use the term focus, but I was going to use something less polite. And the idea was to be able to teach them why some tumors, for example, like this one here, I think it's too bright, but the point was to show that this tumor, instead of growing up, as all of the books tell you, this one grows down, goes southwards. This patient presents with fluid coming out of their nose. And literally, the nose specialist was the one who went to operate, thinking there was some funny nose tumor that was causing this. And really what it was a primitive type of tumor of the pituitary, but because of its nature, it loves bone rather than brain. So it's attracted to bone, making it grow southwards into that box that you heard about from Dr. LaRouche earlier, that sphenoid sinus. A tumor that loves bone is attracted to sphenoid, rather than a tumor that loves brain, it goes upwards. And we can actually have correlates. We can make these diagnoses under the microscope, but more importantly, we can correlate that with the scans, with the abnormalities, and the way that the patients are presenting. So the part that I want to conclude from with the underpinnings chapter is to be able to say, just like you, tumors are members of a family. Families have good apples, bad apples. Tumors also are like that, good, bad, and the ugly. And what causes them in the first place and what makes them grow and misbehave and respond differently has some biological basis behind it. And it's very important to make these distinctions. And that's going to be necessary for us to be able to come up with a therapeutic plan. And somebody asked a question earlier Does genetics or do other factors play a role in your choice of selection of medications, rather than use things in a very, what we call, trial and error? The approach has always been, and if you see the guidelines from major societies, they say try X, and if it doesn't work, go to Y, and if it doesn't work, go to Z. And basically, it's a cookbook recipe that's based on very little in terms of specific information. So my answer to that question, and Deanna is really the one who prompted me to be able to focus on that, and that is, what are we trying to do? What are the goals? Are we just trying to make the hormones look good on paper so we can say you're normalized, go back to your family doctor? The Endocrine Society says just reduce the tumor burden and you're going to be fine. Prevent premature mortality. Well, that's great. Well, what's happening to the patient who's not doing well during this time? So you heard about the classes of drugs already. I'm not going to go through those, by the way. There's also another class, which is estrogen receptor modulators. We didn't talk about that. It's okay, Vincent, we'll do that next time. Seriously, these are tools. But how you use them and the extent to which you use each of the drugs and in which order and by how much is very, very critical. And importantly, it has to be guided by knowing what's wrong with the cell. Okay, if you are going to reach through your toolbox, you need to know what it is that you're trying to fix. So these are some of the abnormalities and the genetic abnormalities that you heard about earlier. We've now come to know that there's different types of pituitary tumors, different types of cell lineages, different types of genes. And I can tell you, as much as this field has kind of increased, it still is very archaic, to be honest with you. And there's still a lot of progress needs to be made. There's some specific abnormalities. The bottom line is this is not a cancer. So looking for abnormalities in genetic pathways has not been as fruitful. There's only one that really we've understood reasonably well, and this is just a growth hormone cell. It basically shows you how that cell is wired. You don't need to know the details other than what that does is allows for the engagement of different electrical networks, which the fancy term for it is signaling, but call it electricity, okay? It's wiring. And those drugs work by interfering with the different wirings. But you need to know how that cell is wired or misfiring so that you know how best to identify the treatment of choice and use the best drug. In many instances, we can now do this even with computer modeling because we can search through drug libraries, even drugs that don't cost too much, sorry to say it, that off the shelf that are available and maybe repurpose them. That's where the field is going in other areas of medicine. That has not happened here so far. But what we do know is that ideally, the cell will have a problem specifically with the somatostatin pathway. And if you put in a somatostatin analog, everything will be shut off. The tumor will not grow. The hormone levels will go down. Everybody's going to go home happy. But that happens in about half of cases, to be honest with you. The other half isn't quite as good. And maybe even a third, it doesn't even touch them. And those are the ones that you heard about before that are referred to not as densely granulated, but sparsely granulated. I won't go through the details of that, but the sad part is that detecting this sparsely granulated, the bad, the not so responsive form of tumor can be detected with an antibody that's available everywhere in Canada, but very few places actually take advantage of that. Now, how insane is that? That antibody is not rocket science. It's sitting on their shelf. They even apply it in other tumors. But because there's no expertise on the provider side, and this is one of the biggest problems that we have in Canada. We've got patients who need the service. We've got clinicians who are willing to provide the service, but those that feed them the information on the other end, which is a pathologist, are asleep at the wheel. Why? Because we don't train pathologists in this area of medicine. Why? Because this is not a high priority. This is not breast cancer. This is not prostate cancer. This is not lung cancer. So what happens? It goes to the very bottom. And what do? They bring the youngest kid in the department and they say, here, you do these. The orphan conditions. Go. Sign these off, along with skin and nail samples as well. Because every time you get a skin shaving, they throw it in a bucket and they get, here, sign this case too. And that's what they do, and that's the truth, unfortunately. And that's not good. So if there's any part of advocacy here, imagine you're making all these recommendations contingent on the quality of information that's coming from the very beginning. And if the quality is poor, garbage in, garbage out. Not a very good situation. And by the way, this is not just the same in Canada. The United States is even worse because it's a bigger country with even bigger disparities. They just don't want to talk about it. But that's another story. Anyways, over the years, we've come to really, and actually Canada and our group was one of the first to be able to demonstrate that what I'm telling you here does have implications to responsiveness to medical therapy. And we were amongst the first to show that the type of tumor is a very important determinant of responsiveness or the lack of to medical therapy, specifically in the growth hormone setting. Subsequently, another group was able to find that there's a surrogate for detecting this type of tumor by means of looking at what's called the T2. T2 is a signal that's acquired whenever you have an MRI. Whenever you take an MRI, the magnet either goes in parallel or perpendicular to your body, and you get what are called T1 and T2 weighted images. That's routine. And the idea was that now looking at the T2 images gives you information that correlates with the type of tumor. So even before you have your surgery, you can come up with a guess of what's the likelihood of a type of pituitary tumor that you have. And I'm proud to say that many of the endocrinologists in Canada, and including myself, were able to come up with a paradigm. Canada was the first to actually come up with a paradigm on how to choose certain classes of medications depending on the type of growth hormone tumors. The Americans never acknowledged that, and they published it 6 years ago, never even referenced what we did. But that's okay. The third chapter has to do more with what does all of this really mean in terms of how you feel. And as I said earlier, it's a syndrome, and keep your eye on all components of the body, because if things are not going well, every part of a body is a suspect. Most importantly is the heart. Why is the heart the problem? Now, everybody will tell you, whenever you ask them, I have a perfect heart. I've got a 90-year-old patient, by the way, right now with acromegaly. He survived. He's done well. Touch wood. But the biggest problem right now is that he is having trouble being independent, physically independent. Why is that? And I have almost a dozen such patients in their 90s. Vincent, when he was working with me, probably saw some of them as well. And here's what happens. Having too much growth hormone for a long period of time causes the heart to be big, strong, except for one problem. Like rubber, it doesn't have elasticity anymore. So its ability to be able to contract is one thing, but you need to be pliable to be able to relax so that the heart can fill properly. Well, if the heart doesn't fill well, it's not going to empty very well. And that filling defect, the ability of the heart to be soft enough to fill, is called diastolic dysfunction. And one of the things that I've tried, and several other groups have tried also, is to be able to emphasize that looking at heart function by ultrasound early enough, looking for the earliest manifestations, not the late, not when the patient is huffing and puffing and is already in congestive heart failure. That's obvious enough. That's not going to help me very much. I want to be able to detect early heart dysfunction so that I can tell who's going to get into trouble so they don't end up in a wheelchair because they can't move, And I want to know, because those patients who have early diastolic dysfunction start to feel fatigued. The F word is the most troublesome in all of medicine, in all of our lives. If we're feeling fatigued, we cannot enjoy our lives. We don't do very well. We can't do much. And if there is one thing that I have learned, is that getting to the underpinnings of why we don't feel well is so incredibly crucial. And the heart is one very important part of this. And the reason being, growth hormone and IGF-1 affect not only the heart, but also the blood vessels and the kidneys, which is all part of the equation because the kidneys provide also the blood, maintaining the salt and water. So that pump is dependent on now the blood coming in, the oxygen coming in from the lungs, and it has to fill and empty properly. All three parts have to work perfectly so that this whole system is functioning properly. In its absence, even a subtle defect is enough to cause a disturbance, which clinically means that you don't feel well. You feel tired. You feel like your legs are made of lead and you cannot go out for a walk, run, or bike, or do any of the things that you expect of yourself. And this is what we call cardiac remodeling, which is just a fancy way of saying that the heart is getting stiffer and it's showing early signs of dysfunction. That's what it looks like in the picture. And I want you to keep this picture in your head because that's what the heart starts to look like. You can see on the black side from the left, the chambers, and you can see that it's not only getting thicker, but as it gets thicker, you can also see that there is less of its ability to be able to suck in the blood, as I said, to be able to fill so that it can empty properly. And we can measure these complications by, as I said, early diastolic dysfunction, and these can be assessed by any cardiogram. But the important thing is that as a patient, as an endocrinologist, you have to ask for that. Not for the ejection fraction, not for the late abnormalities, but for the early diastolic, so we can do something about it. What that means is this true? Am I telling you something that's valid? Well, the proof in the pudding is the ability to be able to actually take up oxygen. So here's what happens. When you and I know this is 4 in the afternoon on Saturday, and we all want to, but I got to take you through this because I think you're going to love it when you catch it, and it's a very important concept. When you and I go for a walk, we start to huff and puff. We take up oxygen. And our muscles take up that oxygen. Everybody's happy. But then we get to a certain point where we can't get the oxygen fast enough, and we start to build up acid in our muscles. You know that feeling when you say you've got lead in your legs? That literally is the inability to be able to get enough oxygen in and carbon dioxide out fast enough. You're in a state of deficit. You build up what we call lactate. And that's what stops you. And interestingly, athletes, when you're really, really fit, they don't seem to want to stop. You know why they don't stop? Not because they can't get the oxygen more in, because their muscles will no longer build up the lactate. Okay, that's a measure of fitness. We can actually measure this, and we have the tools for it. And what we were able to demonstrate is that if your growth hormone levels are abnormal, you start to build up lactate earlier. So when you're tired, it's not in your head, and you're not making it up. There actually is a biological reason for it. We can measure it physiologically. And we were able to do studies and demonstrate that if the opposite end, the people who don't have enough growth hormone, if we give them back growth hormone, just enough, we can actually restore this, and we can make people feel better, and they can walk and cross the street without feeling tired. And that's called the ventilation threshold, if you want to know. We're able to demonstrate also the opposite, that as we bring IGF-1 levels down, we can actually improve vigor. People can actually feel better and less tired. We're able to demonstrate that indeed oxygen and oxygen delivery and uptake are dependent on these changes in growth hormone IGF-1. So in summary, growth hormone excess is not a good thing for your heart. It's not a good thing for your muscles. And it can affect the ability of the gas exchange in a way that means it's more than just hormones. There is a disturbance that can be identified at the level of the tissues. This requires a lot of work, and I've tried to summarize almost 30 years of work in one couple of slides. But I'm hopeful that the field of genetics, of radiology, of pathology, of all of these things will give us all of the elements that we can use to put them forward in models that can help us better understand what's happening to you as a patient, and to be able to work together so that we're not shooting from the hip, we're not guessing, we're actually using very objective means. It's like you bringing an electrician in and figuring out why your lights are coming on at the wrong time, in the wrong room, at the wrong place, and doing it not by him having to unscrew bulbs randomly, but rather being able to go to the circuit board and figure out exactly what's wrong. What that means is that you need a team of people, and you've heard this over and over again, but you need a team of people who aren't just dedicated. They need to be intelligent, motivated, and most importantly, they need to talk to each other all the time. And they have to be united on the front of working together to figure things out. It sounds like a lot of work. It requires a lot of dedication, obviously. But most importantly, I think it requires also a patient who's able to be part of that team. And that's what an advocacy group tries to do. So I'm going to stop at this point, and I thank you for your attention and for persevering on a Saturday afternoon at 4 o'clock. Thank you so much.
Thank you so much, Dr. Ezzat. Do we have time for one or two questions?
Of course. Yeah.
Yeah.
Anybody?
Anyone? A couple of years ago, I had unexplained heart palpitations, short of breath and sound exertion, had all of the cardiac workup. Everything was fine, except for I failed this treadmill stress test and still had heart palpitations, but they couldn't find anything else on any other diagnostics. So would that be from the elevated IGF-1?
Potentially, yeah.
Okay.
And what that means, I obviously I don't know the specifics, and I don't want to sound like I'm being dogmatic, but all too often people look for the extreme conditions. They're looking, especially 9 times out of 10 people who come in with chest pain, they're looking for coronary disease. They want to look for a blocked vessel. They want to either open it up or give you a cholesterol pill. Off you go. But there are people who would be like yourself, and we've now, and if you have, and if a member of the team is a cardiologist who's attuned to these early changes, they will understand exactly what you're talking about. And it's not normal, and it should not be left unattended. It is not meant in any way to be alarmist. On the contrary, it means that you're actually lucky enough to know that there is an issue which can be measured and monitored so that it does not lead ultimately to something much more significant.
Great, thank you.
Thanks so much for the talk, Dr. Ezzat. Really cool to have the honor to receive the 30 years wealth of knowledge kind of synthesized to all of us in the room. So it's really great. I wanted to kind of follow up maybe kind of along the cardiac realms. I thought it was really cool to kind of hear about kind of the cardiac remodeling. I was wondering what kind of the timeline for that is, right? How early in the stage of the disease, does it begin? How long do we have before it reaches to a point of diastolic dysfunction? And I assume there's probably some heterogeneity as well by maybe demographics or subtypes of the tumor as well.
Yeah, that's a good question, Saif. The short answer is we don't really know, but I'll tell you from cross-sectional studies, these are changes that probably occur more over months to years rather than decades. And you're right, it's a reflection of cumulative risk factors. So those that have a genetic predisposition, then you add to it high blood pressure, diabetes, cholesterol, so forth. But my point is, above and beyond these traditional classic risk factors, growth hormone, as was mentioned earlier, is a trigger, and it's probably a trigger not so much for the heart muscle itself, but rather for what we call the stroma. The stroma is the connective tissue between the muscle fibers. You know, when you eat meat, if you look at steak, there's these fibers in between. That's stroma. And when you have too much growth hormone IGF-1, that stroma starts to grow. And it's that growth that contributes to the overall increase in size, but also reduces the elasticity. And that's why this muscle does not have the plasticity that it used to have. So that's another additional factor to all the other factors. But the short answer here is that this is months to years. And this is why the recommendation, practically speaking, is that an exercise echo would be appropriate, perhaps even once a year, especially if there are symptoms. If you're feeling perfectly fine and you can, run and do all of the things and you don't have any problems, that's wonderful. It's probably better than anything else. But if you're already kind of on the borderline, you need to tease out some underlying problem that's contributing to this, and this would be one avenue.
Thanks so much.
Perfect. Oh, Mark, yes.
I just wanted to say something personal. I want to thank you for 27 years ago picking up the pieces from my last endocrinologist, putting me on the Sandostatin LAR study at Wellesley Hospital.
Oh, goodness.
And getting me sorted out. And as a group, I'd like to thank you for being such a great educator and champion for acromegaly in Canada.
Thank you. Thank you so much. Appreciate it. I should say I learn from the best, and the best are the patients. And it's the patients that have taught me, and I have tried to share some of my wealth with. I was very proud, I have to say. So you guys teach me, and in turn, I teach the Ali Perptanis and Vincent LaRoche, who made me very proud today. So thank you guys for passing on the torch. It's very kind of you.